together, we can move the needle from chronic disease management to optimal health. We have an opportunity, a unique opportunity to exactly do that. If you think about it, we actually collectively can do exactly that. When I say over the last 4 or 5 years, we've been talking about how we shift from acute urgent care to chronic disease, right? I mean, anybody can take care of a sore throat or a laceration or bronchitis or a UTI, but the point is, how do we get that patient back in the doors to say, now let's talk about your smoking habits, or let's talk about your blood pressure problem that we've never talked about. So we're obviously talking about shifting from acute care to chronic disease management. There's two principles to get to optimal care. I've been dissecting this out in multiple ways. In my head, as simple as you can get, we need to do two things. If we can understand that this is 2022, and sometimes we forget, and the reason I say that is because some of the tools that we use today is 50 years old, 20 years old. It's outdated, yet we still use it. Not because of any other reason, because we're creatures of habit. We've been using it, it works, but it's outdated. Think about the definition of diabetes or hypertension. If you ask a layperson in the hallway here, what is hypertension? High blood pressure. What's sugar? High sugar. You ask one of us, then you say insulin resistant, gets a little sophisticated. Then you ask an endocrinologist, he'll get even more sophisticated. But the reality is, if you start getting to the root cause, is where we need to be. So one is our tools are old, okay? And two, we don't even know how to define a disease. Think about it. Does anybody really know a definition of hypertension? I don't. Maybe you guys know. Diabetes, other than high sugar, insulin resistant, we don't really know, we don't define it, even though we can, but we just never got into it. So the reality is, disease is nothing more than signs and symptoms. It's a constellation of symptoms. We bucket it together and we say, you have high blood pressure. We bucket this, you have diabetes. We bucket this, you have depression. It's not really the actual cause, right? So we need to actually forget the current definition, and it's 2020. We need to redefine what these diagnoses are. If we can redefine these diagnoses, then what will happen is we'll then start looking for why the problem occurred in the first place and not treat the what. The what is treating the blood pressure, right? I mean, like I said, I don't have to be an MD to manage blood pressure. I really don't. I have 5 drugs in the ER. I can titrate either one of them. It doesn't take rocket science. I always tell anybody, what blood pressure do you want? I can get it there. Tell me what you want. If you're 220, I can get it to 118 precisely if you want it in the next 3 hours. But that's still not solving the problem. You're just looking good to the eye. The monitor looks good. Patient's happy. Everybody's happy, but you have done squat. This is a 47-year-old, basically comes into your clinic center tomorrow or yesterday. She's basically coming in and you think maybe she's got some coronary risk factors, maybe she's weight, blood pressure, whatever, some of the associated numbers that you have tied in with her. So you want to get a cardiac risk score. So what do? What will you tell her that your risk score for a heart attack in the next 10 years is X%? What tool are you going to use? Framingham study. So you actually can now go into an app and pull up a Framingham study. You have told somebody an inaccurate information, absolutely a false statement you made. Absolutely. Framingham study is 1948. This is 2022. So here you are in the patient's room, you pull out your iPhone, you look like the coolest doc in town, you're like punching this in, and say you have a risk score of 5% or 2% or whatever, right? So now you have this lady that walks out of your office with a false illusion that she has a 2% chance of having a heart attack in the next 10 years, so she's going to go buy a bag of potato chips now on her way home. I've always said standard of care is the minimum care that you would want to do to stay out of trouble. That's how I define standard of care. What's the minimum thing you need to do to skate by and not get in trouble? And so if you really look at it, if you were in the real outpatient fee-for-service world and CMS was actually, you were checking off the guidelines for CMS saying, is the blood pressure met, is the A1C met, and all these parameters that they want you to meet, you would have met most of the parameters, yet the patient's not healthy. But those are the measures that we are expected to report, so we falsely think that's okay. What is the right care, and how do we define it? And we talked about it earlier today, and really the story is more personal to me than anybody else, is that had I known what I know today, my 83-year-old dad who recently passed away be here today for another 10 years. His primary care doctor, great guy, he managed all the numbers perfect. A1C is great. PSA is perfect. So by the time he finished managing the numbers 4 years ago, he was on 13 different medicines, each one managing another number, but it looked good. On paper, he looks amazing. So if you really think about it, we didn't do anything but just control the numbers. That doesn't mean you solve the problem. The problem is still there. Earlier, we defined right care, and we say that really we as clinicians need to look at every patient that walks in that door and treat them like they're your brother, sister, mother, father, sons and daughters. If you do that, that's the definition of right care. But I need to be thinking, how would I treat this person if this was my mom? That's your litmus test, ultimately. If you can go home or put your head on the pillow and say, yeah, I would have treated my loved one the same way, then you did right care. Chronic disease management is great, but the real reality is we need to go deeper and find out, can we actually get the root cause? 9 out of 10, if you spend enough time, you will know what the triggering points are. Like I have bad cardiac genes because a lot of folks in my family have cardiac issues. I don't smoke, I don't have hypertension, I don't have diabetes, my lipids are fine, I don't take any medicine, but I have bad genes. So it's like, tough luck, Patel, you're stuck with bad genes, but that's not true. That's what we've been told, that we can't modify this. You can modify. I always told my patients this. I said, you can modify this, you can't modify this, you're stuck with it. I've been telling them wrong. So really, it's like loading a gun, and the loaded gun is there. Now, there's triggering factors that's going to trigger that. So if you can avoid the triggering factors, even though you have bad genes, you're not going to trigger a bad event. So the point of this would be to say, even if someone's got bad genes, it's not okay, but it's treated as loaded gun. Make sure more of the stressors are eliminated. And if we can do that, then it's not going to go off. We need to say, ask for the why did this happen, not what happened. Blood sugar went up, lipids are up, your sugar, A1C is up. That's the what. That's the result of something. So you need to say, why did it go up? What triggered this to go up? And then you can try to figure out the triggers. And I can almost guarantee you that the triggers will be a handful of triggers that are about 8 triggers. There's about 8 triggers that's going to trigger these things. So if we can manage these 8 triggers, and we know the 8 triggers, but the question is, how do we manage them, right? That's always a dilemma. But we need to know first, then we can tackle the problem. Right now, we're just saying, I solved the problem. The sugar was 420, now it's 120. A1C was 8, now it's 6.2. I'm a great clinician. And that's what we're stuck with that. So we need to kind of dissect out and then treat the why and not the what, right? I mean, of course you got to treat the sugars, definitely, but you got to go back and treat the root cause. Is the problem is so big, so we shy away from it because it's just too big to attack. So we need to break it down in bite size. That's going to influence what we do tomorrow.